version, a cephalic presentation. This is a way we can do to yes, to facilitate the whole process. But what I've heard from this young daughter, she said, I've never heard about ECV. I don't want to know about it. I don't want to learn it. I will never do that. This is an astonishing phrase. This is an astonishing statement, mainly because it comes from a very young doctor. And this reflects the kind of fear we have from professionals. And this kind of fear will reflect too on the woman. Every day we receive in our hospital people or women that comes with a breech presentation, and they are very afraid from this kind of childbirth. And many times we've heard and we meet people that fear childbirth when we have a breech baby. And this reflects on the statistics. This is the prevalence of breech births in my hospital. We can see here, we may know the Robson classification, and the group 6 and group 7 are breech births. And we can see here in our hospital, we have around 10,000 childbirths per year. And we can see here we had last in 2011, 2019, more than 300 breech births in our hospital, but around 80% of them were C-section, because women don't want to have a vaginal childbirth when their babies were in a breech position. That means that we have only 20% of vaginal childbirth in our hospital. And this is the rule, and this is the rule here in Brazil. But in Brazil, as a general, only 10% of breech babies will be delivered vaginally. And this is the rule too all over the world. If you see United States statistics, we will see that less than 10% of babies will be delivered through vaginal delivery. And I think, I don't know how are Indian and Middle East statistics, or in New Zealand or in other countries, but I suppose they are the same, because all over the world, people fear breech births. And this is not a new thing. If we track the literature back to the 20th century, we can see here that in 1950, people already feared childbirth. This is a paper published in I think, 1959. And you can see here the title of this paper: Reduction in Perinatal Mortality and Morbidity in Breech Delivery through Routine Use of C-section. This was published in 1959. And in that time, I think there should be some reason to fear breech delivery. We can see here that in babies that weighed more than 2,500 grams, we had a 2% mortality in breech birth. And this means that usually they were term babies. And if we see and if we look these statistics, we will see that in 100 babies, 2 should die in a breech delivery. And because of that, people feared childbirth, and they stated that breech is not a normal presentation. This is an abnormal presentation. This is a pathology. And this is why people call this kind of presentation as an anomalous presentation. Anomalous means abnormal, means disease, means pathology. And why they stated breech birth as a pathology. This author said because of the 5 special problems inherent in breech presentation, there is a high mortality and morbidity rate associated with breech delivery through the vagina. And because it was impossible, they said, to predict in advance which baby will be lost or damaged as the result of vaginal breech delivery. And then they concluded that any patient of over 35 weeks gestation who enters labor with a living baby in breech presentation should be delivered by C-section. Then this was already stated more than 60 years ago. This is not a new kind of thought. Then breech deliveries were seen as a dangerous birth. In 1950 in the US, they estimated there should be more than 13,000 babies lost each year because of a breech delivery. And it's curious to see the kind of discussion that they had at that time. One of the things was about informing the mother. The conclusion of the author of this paper is that they should not inform the mother that she had a breech baby, because this should cause fear in this mother. And they should procrastinate or give this information only when the mother was already laboring. And the mother should say, I'm so glad I didn't know it was a breech. I would have been worried to death. This is a very curious thing to show us how things were already discussed in that time. But one very important thing to know, and a very important question, we have to ask how breech babies were delivered in that time in the 50s. And I will show in the same paper, the author described the kind of practice they had. And we can see that in that time, many women received a kind of drugs, Demerol, that is an opioid, and scopolamine for sedation of the woman. Then the woman was not awake in the time or in the moment of the delivery of her baby. And beyond of that, they were used to do a kind of maneuver to bring down, to take the feet of the baby and to bring it down. This was a very common practice in that time. And I think we could add one more information. In that time, we don't have yet a very important technology. We are not, this is a kind of critic sometimes the humanization movement receive. Some people say that people who defend the humanization of childbirth are against technology. This is not true. In that time, ultrasound was not yet available. Then we have, we can see that are many important informations that should contribute to this kind of bad results. And I don't know if you know it, this kind of painless childbirth or what was called the Twilight sleep. This was brought in the beginning, early 20th century, the use of morphine and scopolamine to put the woman in a kind of clouded consciousness. The woman should feel pain, but she would forget it after childbirth. She would not remember the kind of pain she had during childbirth. And this kind of twilight sleep morphed into different forms and other drugs through 20th century. Well into the 70s, most women were anesthetized or asleep, and their babies pulled out with forceps when they were cephalic, or they should be brought up if they were breech birth. This was a terrible thing, and I'm sure this should contribute to this kind of bad results they had in that time. Then the trends in vaginal breech birth are shown in this figure, and we can see that in 1993, the rates of vaginal delivery for breech birth were already too low, only 30% in Dublin, for example. And this was the same in other countries too, including United States, including Brazil, and I suppose including many other countries. Clinicians' attitudes towards delivery of a breech-presenting fetus have been influencing heavily by those kind of published data. And as vaginal breech delivery became less prevalent, more and more birth attendants became skilled and inexperienced at breech delivery. And this happened during the second half of 20th century. And the findings would suggest that vaginal breech delivery in the future should be limited by the decreasing numbers of clinicians who are or who were adequately skilled to conduct these deliveries safely. And I think we entered the 21st century in this kind of situation. I will talk you something about the Term Breech Trial that was published in 2000. And many people blame this Term Breech Trial, which I will call TBT, as the reason for the decline of breech deliveries all over the world. But this is not really true. When the TBT was published, the vaginal breech birth rates were already too low, less than 20% in many countries all over the world. And I think we arrived in this figure. This figure was published in UpToDate. That is a very important reference all over the world. Many people will consult this reference, and here is the orientation they give to professionals. And we can see here that first of all, we have to see if the woman has any of the following conditions, like any contraindications to labor or vaginal delivery, previous C-section delivery, which many consider a relative contraindication for breech delivery, a gestational age less than 36 weeks, need for induction of labor, and ultrasound examination showing any of the following, like a foot link or incomplete breech, an estimated fetal weight between 2,000 and 4,000 grams, fetal anomaly that might result in dystocia, and hyperextension of fetal head. If any of these conditions present, women should be recommended a C-section. But if they don't have any of these conditions, then if we have obstetric provider skilled in breech delivery, personal and facility resources for emergency C-section, and pediatric provider ready to perform neonatal resuscitation. Then if these present, then the woman should be allowed to have a vaginal delivery. This is a very interesting to note that what I can see here, the system decides to allow or not a vaginal delivery. We don't see here woman protagonism during labor. Because even here, we can see if when the system allows a woman to have a vaginal delivery, this should be done after discussing risks and benefits of a vaginal versus C-section, and even then suggest a C-section. A vaginal delivery is not allowed here. The first step is to suggest a C-section. But if the patient opt for a vaginal delivery, then this should be done. But what we can see in the real world, women usually don't find obstetric provider skilled in breech delivery. This is the problem. In the real world, we will hardly find this kind of condition. Then many women should opt for a vaginal delivery. But if they don't want this kind of provider inside hospitals, some of them will find or will seek for a vaginal breech delivery outside hospital, and many times with midwives. Then this is the kind of thing we can see in the real world. Well, everything I will show here is what we can see in the conventional system, in the hospital system. And after my presentation, we can talk something about it, about the meaning of this kind of situation. Anyway, guidelines talk something about counseling in breech births. And for example, the guideline in the United Kingdom admits that clinicians should counsel women in an unbiased way, in a way that ensures a proper understanding of the absolute as well as relative risks of their different options. This is I think this is a very comprehensive step and to talk and to counsel the woman in an unbiased way. I think we should come back in this concept after my presentation. What is an unbiased way to counsel women about breech births? Can we really do that? Can we really do in a system where more than 90% of women are submitted to a C-section because of a breech presentation? In the real world, this is not an easy thing to find. Well, this is a very interesting review. It was published last year, and they compared here the different guidelines of 6 countries: the United Kingdom, in Canada, Ireland, in Australia and New Zealand, France, and the US. The best of the guide of all of these guidelines was made in the United Kingdom. They usually use very good methodologies to build guidelines. And I will focus in this guideline first, but if you want, you can see the others too, but I will focus on the English guideline. It was published 5 years ago, and all of them agree something about counseling. Counseling should consist of a discussion about short and long-term risks and benefits of planned vaginal breech birth versus a planned C-section for mother and fetus in an unbiased way. I've already talked about that. All of them agree about that. But I think we have talked about this in our last session. We have seen the limits of the risk and benefits discussion. I think this is a very poor step. It's a very poor strategy to engage women in this kind of vaginal birth. Anyway, I think the English guideline has some qualities too. We should not blame it at all. It has some qualities. For example, outlines specific that should be discussed with the woman. There are no difference in long-term neonatal outcomes regardless of birth mode. This is a very important information. Selection of appropriate pregnancies and skilled intrapartum care may allow for a planned vaginal breech birth to be almost as safe as a planned cephalic birth. This is another very important information. And maternal complications are least with vaginal breech birth, higher risk with planned C-section, and the highest risk with emergency C-section. And we have to consider too the long-term risks of a C-section, because the risk of C-section to future pregnancies, vaginal birth after a C-section risk, this increase with repeat C-section in the future. Then these are very important informations. We have to be able to discuss, even admitting that the discussion about risks and benefits is very poor. It's not enough. We have to discuss the meaning of birth. I think this should be the first step. The discussion about risks and benefits, if necessary, this should be a second or even third step. This should be not in the beginning of the discussion or at the beginning of counseling. The risks of perinatal mortality of vaginal breech birth and versus C-section are presented here. And we can see that a cephalic vaginal birth risk is 1 in 1,000 childbirths for vaginal birth. The C-section has a risk of 0.5 in 1,000, and the vaginal breech birth a risk of 2 in 1,000. In a relative, if we look at the relative risks, this means a 4-fold risk for vaginal breech birth compared to C-section. But it's very important to look at the absolute risk because it's too low. But I will talk something about the Term Breech Trial. I will call it TBT. It was published in 2000, and it was made it was a multi-centric study in 121 centers in 26 countries. More than 2,000 women with a singleton fetus in a frank or complete breech presentation were randomly assigned to planned C-section or a planned vaginal birth. And the results were very bad for vaginal breech delivery. Because of them, more than 1,000 assigned to planned vaginal birth, indeed only 56% delivery vaginal, but perinatal mortality, neonatal mortality, or serious neonatal morbidity was significantly lower for the planned C-section group than for planned vaginal birth group. And the interpretation and conclusion were that a planned C-section is better than planned vaginal birth for the term fetus in the breech presentation. And serious maternal complications were similar between the groups. Then, I remember well, I was in a resident when this trial was published, and it changed everything. When I was a resident, I was used to see sometimes vaginal breech deliveries, but after 2000, this almost disappeared in my country, almost disappeared. Breech vaginal birth became something almost exceptional, very rare. Well, but we have to know, and this is a very important trial, it's a very important publication, 2005. It was published an observational prospective study, and it was made in French and Belgian maternity units, more than 150 maternity units, and more than 8,000 pregnant women. And what were the results? Of the women with planned vaginal deliveries, indeed, 71% had a vaginal deliveries. And the rate of combined neonatal outcome measure was low in the overall population. And in the planned vaginal delivery group, it was the same. The conclusion was, in places where planned vaginal delivery is a common practice, and when strict criteria are met before and during labor, planned vaginal delivery of singleton fetuses in breech presentation at term remains a safe option that can be offered to women. Totally different conclusions, completely different conclusions. The first one recommended C-section to everyone, and now we see that that was not true. And later, the following year, I think this demolished completely the TBT, because there was made an analysis of the original and new data from TBT, and they've seen very serious concerns through the study design, methods, and conclusions. First, in a substantial number of cases, there was a lack of adherence to the inclusion criteria. Second, there was a large interinstitutional variation of standard of care. Inadequate methods of antepartum and intrapartum fetal assessment were used, and a large proportion of women were recruited during active labor. In many instances of planned vaginal delivery, there was no attendance of a clinician with adequate expertise. This was, I think, this really unmasked the TBT. Although the damage was already done. But the conclusion of the authors, the original Term Breech Trial recommendations should be withdrawn. We should not use that conclusions anymore. But we have to admit the damage was already done. But we should not blame only the TBT, because we have seen that the vaginal delivery rates were already too low even before the TBT was published. I like very much this group, Breech Without Borders. They have many important resources. They give courses. They are a very good group. And one of the things they made is this kind of review. They reviewed dates after TBT, and the answer or the question they made was, how does the TBT compare to recent data? Well, we know that recent studies do not support the findings of the TBT. Two large multi-center studies in France and in Belgium, I've already mentioned it, these two studies. One of them, it calls Premoda, it here, 2006, Premoda, France and Belgium, and they do not support the findings of the TBT. And after, some national registry studies have found no significant difference between planned C-section and a planned vaginal breech birth. A meta-analysis and other registry studies have found some short-term advantage to planned C-section, but advantage is significantly less pronounced than in the TBT. This figure shows this review. We can see here the first in the top, the TBT data. Indeed, the TBT data show it a very different and a very higher mortality rate for vaginal breech delivery when compared to a C-section, a planned C-section. 13 deaths in 1,000 for vaginal breech delivery compared to 3 neonatal or perinatal deaths for a planned C-section. This is indeed a very large difference. But what can we see after TBT? The Premoda here, no statistical difference. And the following studies, even when they show some statistical difference, and even when they show that the numbers for a planned C-section are better, this difference is too short. It's too short. We have to recognize that. Well, this is a meta-analysis that was published recently, 2016, and they show the same thing. They show the same thing, or almost the same figure we have seen in the slide I presented you before. Almost the same thing. They recognize that perinatal mortality and morbidity in the planned vaginal breech delivery were significantly higher than with planned C-section, but the relative low absolute risks are low. Then they recommend that individualized decision-making on the route of delivery should be done. This is a very important study that was published in 2005 in the Netherlands. And what they show here, they assessed how elective C-section, how the increase in the elective C-section rate because of breech deliveries impacted on the results for mother and how they should impact, or how they should impact on the future results, even for the babies and infants. What they've seen, the altered attitude of obstetricians with regard to term breech delivery after the first results of the TBT in 2000 led to an increase in elective C-section in Netherlands for breech deliveries from 25 in 1999 to 64 in 2004. This should save around 19 babies, but at a cost of 4 avoidable maternal deaths, 9 fetal deaths in future due to uterine scar, and 140 potentially life-threatening maternal complications in future pregnancies. Then this should be the cost of doing a C-section or offering a C-section to every woman because of breech presentation. Then information to the patient should take into account not only the short-term benefits, but also the higher long-term risks, and vaginal delivery following strict selection should be preferred. This is the conclusion of this very important publication done in the Netherlands. Well, here we can see the changing of positions from ACOG in the US. Soon after the publication of TBT in 2001, the ACOG recommended a C-section for every woman presenting with a breech delivery. This changed in 2006 after those reanalysis and after the publication of the Premoda in France. And this was reaffirmed here in 2018. But even then, we can see here that they don't encourage women to have a vaginal breech delivery. Because if the woman wants, when the woman wants to have a vaginal delivery, they say here that she should be informed detailed informed about the risks of perinatal or neonatal mortality or short-term serious neonatal morbidity, that these are higher than if a C-section is planned. I think they induce women to choose a C-section delivery here. This is my impression. I would like to hear you from this. I would like to hear your impressions about this kind of recommendation. Well, selection of appropriate pregnancies and skilled intrapartum care may allow for a planned vaginal breech birth to be almost as safe as a planned cephalic birth. This is, I think, the English or the guideline in the UK encourages a little more than the US guideline. But the problem is, are doctors, midwives, and midwifery students adequately prepared for vaginal breech birth in clinical practice? Because this is the question we have. Because we have seen things changed a lot. And almost or more than 90% of breech births are delivered through a C-section. Vaginal breech delivery is almost abolished in many, many hospitals all over the world. Then we have to question what expertise in breech birth is, what is the meaning of expertise? How can we judge about that? How can we assess if professionals are expert in breech birth? Many guidelines refers to clinical expertise as an essential safety factor in vaginal breech birth, similarly to other guidelines globally, many. But when breech expertise is unavailable, the safety and availability of vaginal breech birth decline. Yes, we have to admit that this is really true. The problem is, what is expertise in breech birth? Minimal empirical evidence exists to guide identification and evaluation of expertise. In the TBT, expertise was judged by the own person, was judged by him or herself to be skilled and experienced at vaginal breech delivery, and confirmed by the head of the department. Then it was a self-assessment. Well, I think a self-assessment, it's a good thing. We have to self-assess us. But this is enough? Is this enough? How can we assess this? Some people have been studying that. And I think this is a very important thing, because we have to know, or we have to establish some kind of standard for maternity care for professionals attending planned upright or planned breech birth anyway. And I think this is a very interesting publication. I read it. It was published in Midwifery 2016, and they established some criteria or some steps that should be considered to establish a standard of care for breech birth. And they describe here many skills. I will not read all of them, but I think we should come back here if we want to advance this kind of training for people, because yes, the authors of this paper established a series or many skills that are indeed very important for a person who attends breech birth. We can see here some skills, the use of right technology, the maneuvers for breech birth. Yes, they are very important. And every person that assists or attends a breech birth should know them and should know how to apply and when to apply this kind of maneuvers. And some others additional core skills, like, for example, competence and confidence for supporting physiological birth, whether the infant is breech or cephalic. Communication skills, these are very important. Trust in birth, because if we don't trust in birth, we should not trust in a breech birth. And also escalating and acting appropriately in an emergency and manage the distress of others. Well, I will not read every skills that are mentioned here, but we should know them. And also the standards for training people. And here are a guide for education and training, the evidence of basic competence, numbers associated with a mentorship period. Yes, people should have practical skills. They should be trained, and they should be trained for people with more experienced people. And also professional updating activities, because we are always learning, and we should update our professional skills, our professional knowledge. And yes, and here are many other important steps that should be done. I've mentioned it, the Breech Without Borders, it's one organization, but there are other, like Breech Birth Network. I don't know if you know them. Yes, I really don't. I've never done, or I've never did their trainings, but they looked very interesting. And we have developing our own course here in Brazil for training people for breech birth. Our hospital never abolished breech birth, but you have seen even then our vaginal breech birth rates is only 20%, because if women don't want to have a vaginal delivery, even after counseling, we do a C-section. This is the kind of guideline exists in Brazil, and as a hospital we have to obey them. But I'm very happy because yesterday this very beautiful lady gave birth vaginally to this baby. It was a breech baby, and we tried an ECV for 2 times, but it did succeed, And she was counseled, and she was a very trustful woman. And yesterday, it was my, before yesterday, I was in the hospital. And when I arrived, she was already there. 7 a.m., she had 9 to 10 centimeters of dilation. And but she was not in an active phase of second period. And in that time, for a while, she distrusted. She thought she should not be able to deliver her baby. She wanted a C-section in this time, in this moment, but we reinforced the support. She had a doula, and finally, at around, yes, soon after midday, she delivered her baby. And 4 hours after delivering, she had this beautiful smile. She was very happy, and I was very happy too. Well, I think I have already used my time. I will not talk about the maneuvers because I think this is a more practical kind of thing. I think I could talk about them, but anyway, we should have a practical drill, and this is not possible for now. Well, thank you very much. Thank you, Lillie. It should be interesting to know your opinion and to hear what you think about breech birth, what you are doing in your countries.
Thank you so much, Doctor. That was a fantastic session, like always, and we are learning too much from you. Especially, you are talking according evidence-based practice in gynecology, and it is really amazing for all of us to hear such this knowledgeable information. And I have many, yes, in chat box, we're already full. So we have attendees from different countries. And it's so interesting. We have Azadeh Zareh from Iran, Zahra Iran, Irene from New Zealand, Zahra Mehnaz Iran, Dr. Singh from India, and Kiryat Roshini from India, yes. We have Farkhonde Fateme Zahra Indu Singh from India, Shole from Iran, Ruchika from India, Pratip Hasing, Dr. Pratip Hasing, written Ruchika, Ria, Somiya are medical students in final year of MBBS. Wow, lovely. Indu and Priyat Rashini are yoga trainers. It's a pleasure to meet you all. Regards, Pratip Hasing, psychotherapist from India. Irene, mentioned we need to remove the fear of birth and develop clinical skills and work in partnership with the women. What is the intuition, maternal and health provider? And Shole, please show again the previous slide. Sure, Shole. Irene, if the healthcare provider is not confident or fearful of birth, the chances of successful vaginal birth is very low. It's the same scenario when it comes to VPAC. There is no mention of holistic integrated prenatal care. There little insight into the bigger picture. Note the shape of the baby head. Yes, you should not put time and birth if baby and mother are fine. Fateme, written thank you from Iran. Indu, hi, this is Indu from India. Rehane, I'm from Iran. And thank you, everybody. So, okay. Who wants to ask question? If you have any doubt or you want to talk, let me know. I give you access to talk here all. Yeah, please. Who wants to talk? You can raise your hand, and if you have any, yeah, yes, even I guess you want to talk or you want to type. I'm trying to give access. Yes, even you're audible.
Okay,
Hello.
I think Pratibha wants to ask a question, so let's let Pratibha ask, and then we can answer her questions.
All right. So this is Pratibha Singh from India, and I'm so happy to be a part of this wonderful meeting. Thank you so much, Dr. Lela, for allowing me. So I would like to know that as we all are, I guess 5 of us here are medical students from India. We do not get such information while we read in textbook. We do not get such information while we hear lectures. So these information is very, very useful for us because we are yet to start our practice. I work as a psychotherapist these days, but the thing is, when it comes to real life practice, we commit so many mistakes when then we learn. But by these presentation, I can learn what is going on in entire world and what people are actually facing in real life. Thank you so much for such precise information. It can make me understand what not to do and what to do when I see cases for real, because we only see textbook cases which are not practiced every day when we see patients. Thank you so much, Dr. Lela, for such informative details about the practices.
I would like to comment. Thank you, Pratibha. Are you from Delhi?
Yes.
Yeah, good. Well, I think the one very important information is that, yes, we receive many information that are completely wrong. One of them is that breech birth is something forbidden. Many people believe that it's something forbidden. It's something very dangerous. It's something we should never do. We should never do. I've heard that many times here in Brazil. And when a student hear this kind of information, they will believe, because they are still learning. They will believe.
When I was listening to you, I was like, this is something I never thought can happen. Because when I'm going to hospital, I will be learning, then I will understand after doing something wrong. Because I read something wrong in my textbook, which is not updated according to the present day traits and the happenings around the globe. Because back in time, we used to, like, there were no doctors and all the ladies were giving birth naturally because there were so many complications. Now, so many complications, so much of help, so many of precautions doctors are taking, which is like being told by you, which information I got from you is something we need to learn over time. So thank you so much for your inputs. I can understand there are a lot to learn, and we doctors need to update according to the problem arises. Like when Corona came, nobody knew what to do because it's a new thing.
Yes, what we have to know is that breech birth is rational. There is support in the scientific literature, and it is safe. We have heard this from the guideline from the UK. Almost safe as a cephalic vaginal birth. Almost safe. Then this is safe. There is no wrong when we accept and we are present and we do that. No problem. There is no wrong here.
All right. Thank you so much, doctor.
You.
Don't forget Dr. Pratibha that we have other session all with Dr. Edson, and next session will be for 14 July. It is about hypertension in pregnancy. You will hear very fantastic information and true evidence-based practice by Dr. Edson. We have one session every day, every month. Yeah, okay, yes. Even written, the history of medical obstetric textbook were written by men with no experience in childbirth. The midwives at that time were not allowed education, and they shared their skill by verbatim and in the practical environment. Ruchika, thank you so much, Dr. Edson. Zahra Khandejan, thank you. And I'm Leila Irandu from Iran. Thank you so much, Dr. Edson. And Iran, the textbooks are mainly theoretical. Rehane Salar Sadeghi, thank you so much, Dr. Edson. I'm from Midwifery. And Sadiqa from Iran, Rehane, and we have many other attendees, but they haven't mentioned their country. Actually, our registration comes from different countries, from UAE, Saudi Arabia. We have many attendees from Gulf countries and from Middle East and from China as well. Please don't forget to mention from which country we are joining us. And if you want to get your certificate, please turn on your camera. We will provide your certificate of attendance as well.
Lillie,
thank you. Yes, Doctor. Yes, please.
I would like to announce my sister is here. It's Milena. Milena, where are you?
Yes.
My sister is a doula. I would like to introduce her to you. It's Milena.
Hello, I'm here.
Hi, Mel. Welcome. So interesting.
I'm from Brazil, here in São Gotardo.
She lives in a small city in the countryside.
Oh, so lovely.
Welcome,
So interesting.
my sister,
So
my dear sister.
Welcome, Elena.
Nice to meet you, Lillie.
Me too, and all of the group and really family are so happy to see you here. Our family is getting bigger.
Thank you, Lillie.
Thank you so much.
We look forward to hearing your experiences too. Welcome to the team.
Thank you so much. I'm learning now. My English is not so good. I can listen very well, but I'm not so good to
speak. Yes.
I don't speak so much English. But I can understand.
I understand your feeling. I'm in New Zealand and I'm now having to learn the Maori words because I should have done it many years ago. So when I go to the marae and I listen to the experts and we're talking about the spiritual side of Maori and Mother Earth and Father Earth, and learning about all that is also not easy. So I understand that we're always having to learn our languages and our speech.
Irene, I would like to hear from you something about breech birth.
Yeah, please, Irene.
Oh, you want to hear from me about breech birth? Well, I need to go back a long time ago. I think that when I first started, I'm going to talk a little bit about the fear of birth. The fear played a very important role, even though I was at my sister's home births as a very young child. When I went into the hospitals, childbirth was not like what I'd seen with my sisters at home or grandmother's stories. And I didn't understand birth. I learned it from the textbooks. So you might all know Maggie Miles and obstetrics. And I used to sleep on the books, hoping that the words would come into my head. My mother said, sleep on them and you'll remember everything in the morning. But it didn't help me. And I remember in the hospital, when the babies were coming, they would say to me, oh, you can go on delivery suite. I says, no, I'm going to special care baby unit. you know, don't put me in there. But when I went to Saudi Arabia in 1980, the Bedouin ladies could still birth, and many came in without prenatal care. So we had many breech births, yes. And I thought, wow, we don't need to do anything. These babies come by themselves. What I learned that you need to work with women. You need to understand the baby has to be proportionate in size. We need to educate women about their diet. The diet has a huge role. I had a girl that came to me, I think they were planning a free birth, and I just wanted to support them. And she came and she was 33 weeks, but I felt her tummy, you know, it's like, well, we know everything, we're going to free birth. And that's what worries me, if they don't have the education, you know, or the knowledge. So I felt her tummy, and there was no tone in her uterus, and there was too much fluid around the baby. And the first thing I talked about, well, you know, where's the zinc and protein in your diet, and the magnesium? And the other thing was, I says, are you eating a lot of fruit? She says, yes. I says, well, your baby's creating a lot of fluid around it. You need to change your diet. I'm not going to do anything else. You change your diet. And she came back, and the baby turned position. Now, when I talk about the diet and the fruits, in November time or December here, it's summertime, and it's strawberry season and melon season. And the women would eat a lot of strawberries. So when they'd had a previous C-section and came to me, and I looked, oh, your baby was due about November, December, and you had a C-section. And I said, for a breech, and I says, were you eating a lot of strawberries and melons? She says, how did you know? I says, because an old midwife told me if the body's pH is not in balance, then the baby will be breech. So often we can do it just by changing diet. And you know, the other part is the baby must be in proportionate in size to the woman. Okay, now, if I've got a baby that's deciding it's going to be breech, I think we need to look more at the shape of the head. Some babies just want to be breech, no matter what you do. But I use homeopathy. You know, homeopathy, we have several remedies. You know, if there's not enough fluid or too much fluid around the baby, we use a remedy called natrum muriaticum. If the baby's unstable and it's moving about all the time, we change the diet, make sure she's got plenty of zinc and magnesium and protein in her diet, and we would give the natrum muriaticum. So you've got to fix the head space. You've got to look at where everything's coming from. The other one is tuberculinum, for babies that don't stay in one place, and pulsatilla to tone the shape of the uterus. And we talk about this when we will have our homeopathic course come, and all that will come on there to teach these lovely midwives. The other thing is that we're concerned about is, I'll give you a story. It wasn't me, it was a midwife, and the woman was from Asia, and she'd wanted a home birth, but she wouldn't let anybody feel her tummy or do anything, and wouldn't let the midwife examine her. Now, this woman went into preterm labor, and this midwife was called out to another midwife's client, so she knew nothing about the woman, and the baby was 34 weeks, okay? And this is why you need a skilled birth attendant. This is why we need to look at the bigger picture, because she went into preterm labor at home, and there was difficulties with the baby's head because the cervix had clamped around it. So these are the things that we have to be aware of. You know, I've seen it before when babies have been born and undiagnosed breech, and they've had inductions of labor, or, you know, 28 weeks, 30 weeks, and we've had problems with the baby's head. And I think it's the positions that they have women in, because if they're undiagnosed, we've got to look at the gravity. Okay, so if a woman, I had one girl and the baby was breech, and she turned the baby, we changed the diet, it was cephalic. And then 2 days later, she came into labor and the baby was breech again. So, but, you know, she had very quick births and very strong contractions. So we didn't give her a lot of gravity because you're looking at the type of contractions. If you've got expulsive births, you know, being upright can push the baby down too quickly. So coming from a midwifery perspective, we need to look at the bigger picture as to what is actually happening. So, you know, childbirth is, I think the amazing thing about midwives' experience, midwives need to be totally observant, totally aware of everything and the environment and the diet. And if we don't fix the woman's emotional state, you know, it will tense up. So, you know, I had women, and when we go to a home birth, even for a normal birth, if we don't do a clearing prenatally, emotionally, it will come out at the birth. And then you get, you know, obstructed births, you get women who don't release their babies. So looking at it in a really holistic and preventative way, it's a clearing. So childbirth in pregnancy is like it's kind of an end of an era for a mother. Yes, and a new life comes. So it's like when you clear the past and the negativities, it actually helps with a positive birth and a good birth experience. And of course, hands off. I mean, I never do anything at a birth. I just sit and I'll watch and wait. And it's mainly emotional and spiritual support that women want if they've done the preparation and eaten the healthy foods. Make sense? Edson? What do you think, Edson?
Yes, it makes sense. Thank you.
It was a fantastic experience. Gail, do you want to add something with your fantastic experience?
Yeah. It's been a long time since I have attended any breech workshops myself. But I think I would like to, even at my old age, I think I would like to have a refresher course, because when I was watching the slides that Dr. Edson shared, I read something about clavicle triggers where you can get the baby to flex the head with a reaction. I don't know anything about that. I've never read that or seen that before. So if that's from Breech Without Borders, I would like to attend a Breech Without Borders workshop, because I think there's still a lot of things I don't know. And I think back in the past when I've had a difficult breech where the baby was not bringing his head out at the last minute, it gets very tense when this is something that needs to be attended to faster. So I'm thinking if there's a couple of new tricks that I don't know, I want to learn them. So if Lillie can bring this workshop on Zoom where I can learn, and I want to see this reflex, if it's going to make the baby drop the head, because I've had the stargazers at the last minute and they're no fun. And so I'm thinking there's some more new stuff that some young people have learned that I need to know.
When I was in China, I actually saw, and it was actually beautiful, 4 footling breeches delivered vaginally. And the obstetricians were amazing. They just laid the woman on the side. She was on the side in the bed, and they just allowed the baby to descend. And it was perfect. You could see the babies, you know, turn. So like, you know, they didn't push them about to be upright and marching around. I think some of the latest research, I mean, I've seen breech births in water as water births. I think because I think the water stops the expulsive contractions that can push the baby's head down too early. There's lots of things we're learning about breech births and positioning, and it's all to do with gravity and the situation. And that's where the skills come in at the birth, looking at the big picture. What have we got here? You know, how can we get the best outcome for the woman? So there's lots of things we can look at to do to get these wonderful outcomes. And before I went to China, you know, I was a bit afraid of the footling breaches, and, you know, the obstetricians and everybody would go in and lecture and say, oh, you can't deliver a footling breech. And then there you go, I saw 5 of them deliver perfectly. So what is it we're afraid of? How do we manage it? You know, are we looking at the situation, the entire big picture?
Yes, I talked today something about the general picture, but indeed we should have a talk about the intrapartum care, because when we talk about intrapartum care, then we'll talk about the general management, including the maneuvers and the problems that may arrive, or yes, these kind of things you are talking about. We should schedule that for the future, Lillie. What do you think about?
Yeah, sure, doctor, sure. I guess we have another session for 18 August that suppose we talk about VBAC, but actually we had this session in International Day of Midwife. So if you are active from just now, I want to confirm the time and I want to get confirmation from audience. So everybody, if you are ready for 18 August, we can keep this session, continue in that day. And actually, because 14 July is for hypertension in pregnancy, so 18 August we can consider for this session. It is okay, Dr. with you, because I got this date confirmation by Dr. Edson. That's why I know the date is available for Dr. Edson. I booked it since last year.
I feel very glad. I would like to hear more, mainly from the students, the young students, yes, that want to learn. Maybe, I don't know if you will agree, and we can talk about this later. We can introduce some changes in our session, maybe to give some minutes or some time for a presentation from the students, because they will bring some information and they will enrich our discussion. This is the kind of suggestion I'm seeing you here, and I feel you should enrich a lot.
Quiet.
Yeah, sure, Dr. We do. Next time, Pradipha, Indu, Rehane, Fateme, Zahra, Mathu Smita, Milena, Zahra, Mehnaz, Zahra Ria, Mehnaz, and Natalia. It is your assignment, and fresh there. All of you. You have to have a small presentation next time and prepare for 18 August. Are you ready for that? Yes, who wants to talk? Very good, Pratibha, Dr. Pratibha. Excellent, excellent, excellent. Dr. Jones, we can't see you. Dr. Ricardo.
Is he here?
I guess Dr. Ricardo is here, yeah. I saw him. Oh, Dr. Ricardo. You want to hear from you?
We can't hear you.
Doctor, you are audible. Doctor, you are on mute. Yes, you can talk, but I don't know. I can't hear you.
No.
Hello.
Yes, Jana. دوستان عزیز سوال
I have a question.
Yeah, please شعله. Ask. Yeah, میتونی فارسی من ترجمه کنم دوستان عزیز.
I try to hello everyone. I try to
here he is. Hi.
Hello.
Dr. Ricardo, your hat is unbelievable for me. I am in 40 degree. How it comes? I can hear you, doctor. I think you're not audible. Oh, yeah.
There's no voice.
No voice.
Yeah, no voice. No voice. No.
Double tap.
Can't hear you.
Double tap.
Yeah, unfortunately, we
Tapping.
can't hear you. Yes,
Can't hear
sure.
you.
Yeah, it's okay, no problem. We are trying to hear you, but it's not possible.
Can't hear you. Yeah.
Okay. It's
I
unfortunately.
want to.
Yes, surely you can ask, please. Yeah.
I would like to know about the legal issues in breech vaginal delivery in other countries. As you know, in Iran, there is no legal acceptance for breech vaginal delivery as now, these days. When I was a student 30 years ago, we saw a lot of breech deliveries in hospitals, but now obstetricians in Iran don't agree, don't accept this responsibility, and the breech vaginal delivery actually is illegal in Iran. What should we do about this? And we mostly try to change the position and rotate the breech into cephalic and do breech cephalic, breech to cephalic. And there is no legal support and medical support from obstetrician for doing breech vaginal delivery.
Well,
and we can do this.
Question, Shirley. Thank you so much.
Yes, I feel, I think breech birth should not be submitted to the law. This is not a legal thing. It's a clinical thing. This the decisions should be done between provider and the woman. But I regret, I regret if things are this way in Iran. It's the only thing I can do is to regret, because this should be not this way. This should not be this kind of way. Talk something, Gail. You can.
Okay. Are we talking about illegal or protocol? I mean, maybe there's some confusion. Is it a law, a legal law of the country, or is it the protocol and policy of the medical profession? There's a difference.
There is no acceptance for breech delivery in healthcare provider now. As I told you, 30 years ago, there are a lot of midwives, experienced midwives who do a delivery breech in a vaginal position. But now it changes, and we mostly try to change the position, use heat and cold and the lights and other acupressure position, and try to change the breech into cephalic. If they don't rotate, obstetricians don't allow to do vaginal delivery, and there is no support.
But this is a national law. If the provider that tries a vaginal breech delivery will be charged if it tries to attend a woman this way, I didn't understand. it will be charged by, it will be brought to the court.
شما
and-
هستین
آره من هستم. ببین دستورالعمل کشوری اجرا نباید بشه بریچ، یا اینکه خود پزشکای زنان ایران نمیخوان انجام بدن یا غیر قانونیه. آها اینو میپرسن.
یعنی توی قوانین بریچ یعنی اومده که دیگه مثل قبل نیست. 30 سال قبل ما میتونستیم این غیر قانونی از نظر لگال پزشکی، ولی الان وقتی میخوایم انجام بدیم دیگه مستقیم میره سی سکشن، اصلا بهش فرصتی.
یعنی تو پروتکل کشوری هم دیگه اجازه زایمان بریچ نمیدن، درسته؟ منظورتون اینه دیگه؟
فرصت داد ما جایی ندیدیم فرصت داده بشه مگر اینکه خانم فول اومده بریچ رزیدنت ها میفتن روشو ترای میکنن و که اکثرا هم شکست میخوره.
بله. Understand. She says that previous 30 years ago we were allowed to give this chance to mothers to have breech birth, but nowadays there is no chance, and the obstetrician and doctors, they don't let us to practice even for the mothers for breech. They go directly for cesarean section, and even our national protocol is not mentioned that we have a right to help mothers for breech delivery. There's no protocol about that in Iran national guideline.
Okay, so it's policy or cultural, but it's not a law. It's policy or cultural, but not a law. So you're not going to lose your license if you do a breech delivery.
متوجه شدیم. میگن اگر پالیسی دستورالعمل هست یا اینکه علاوه فرهنگی دوست ندارن همکاران ما کمک بکنن، این قانون نیست و هنوز میتونید شما کمک کنین برای زایمان بریچ که به صورت طبیعی انجام بشه. متوجه شدیم؟ نمیدونم جوابتون درست
چون های ریسک هسته، چون های ریسک هست بدون نظر obstetrician ما نمیتونیم این کار تنهایی انجام بدیم.
Because they go on high risk category, that's why midwives are not allowed to conduct a birth without obstetrician permission. So if obstetrician accepts, we can go do breech birth by his allowance and his permission. Otherwise, we are not allowed. And Iran is written. Let me read what's written in the chat box. Yes. Okay. Iran research written. It is because everyone wants to control birth. There needs to be an opening of units with like-minded holistic obstetrician. In New Zealand, we have made steps to break away from the old school. Acupuncture works better when combined with homeopathy and a change in the diet. Fatima is written, yes, doctor says it's dangerous because all of the babies are golden baby and CS is safe for babies in Iran. Iran answered to Fatima, yes, this was the case in many hospitals in China. But taking control shows the fear of the obstetrician and the great fear of litigation. Fatima, but in Tehran, if parents accept, we can do. Okay, thank you, Fatima. Okay, any more questions? I guess we have questions from Matusmita. She was on waiting. Matusmita, please. I give you access to. I'm trying to give you unmute access, but what's wrong? Yes. Matusmita, I want to give you access, but I'm trying to unmute you. Can you try? Matusmita, I give you access.
Ricardo, can you unmute?
Yeah, Ricardo is unmute, but we can't hear.
Can you hear me now?
Yes!
Oh!
I have to change my computer. I was in my smartphone, so I changed to the desktop.
Oh, very good.
I have a question about breech birth. And I am very glad that you invited my friend Edson to talk here because Edson is one of the best in the country. But the thing is, every time I hear about breech baby, I have these marvelous explanations concerning the safety of breech deliveries and the fact that Once we do cesarean sections, we do not improve the well-being of the baby that much. The results are percentually different, but the number of the babies that we really save or the really are really better if we use cesarean sections instead of delivering vaginally a baby in breech position are not that important. And the fact is, in the United States, last year, 2021, almost 50,000 people dying in car wrecks, 50,000 people, and no one ever dares to ask for the extermination of automobiles in the United States. So the thing is that the death of people is not that important. The death of baby is not that important. The important is the control that the system, doctors and hospitals have over women and babies. So I think that the discussion of delivery babies, or pardon me, the discussion about breech babies is 5% technical and 95% political and cultural. Once we understand that the women have the baby to have the children the way they want, once they have the right to choose the place of birth, we will discuss in a different way. The thing is, we keep discussing breech baby around science, but the thing is that science doesn't control the procedures. What controls procedures is politics and protocols and doctors and hospitals and power. And the thing is, it doesn't matter if breech babies are safer. It doesn't matter. Doctors don't want to run the risk that something happens and they will be charged. And that's why the student in Brazil that talked to Edson said, I don't care. I don't want to hear about that because I'm putting myself in risk, not the patient, not the baby, myself in risk, because I am going against the powers, the established powers in the country, the established powers in obstetrics, in medicine, and so on. And so I think we should discuss protocol. We should discuss how to make women understand that it's safer for her to have a vaginal birth, and then these women will push doctors and push authorities and push politicians to make the proper environments, the proper techniques, the proper education for doctors, the proper education for midwives, and then we can establish a new level of discussion, because now doctors cannot safely assist breech babies because other doctors don't want them to act like that. And thank you very much, Irene, my dear friend Irene. I hope you are well after the surgery, Irene. And thank you very much, Edson, for the brilliant explanation about the techniques and the reality of breech birth in the world. Thank you.
I would like to comment your speech, and I agree with you, because to the point of view of the technique, it looks there is almost no difference in risk when we look at the C-section and a vaginal birth. And from the point of view of the history, I think we are today, nowadays, we are safer than before for assisting breech birth. Even to the point of view of the technique, we improved our technique. At least the people who applied to learn it. I'm not saying in the general as the big picture, but if we study and if we apply to learn the technique, I think we have nowadays best or better techniques than before. I've shown you how breech babies were delivered in the 50s. They were brought down. There were not good techniques in the past. They were worse than today. And even talking, I'm only talking, I'm not talking about the politics. I'm not talking about the ideology. I'm talking only, I'm focused only on the technique, and even in the technique, and I believe I reinforce what you said. There are some studies that show that even when they analyzed the bad results of breech birth, they've seen that we should prevent at least 50% of that bad results. We could believe, we could prevent it even more. Then I agree there, the problem is not the technique, because the results are virtually the same. There is no difference.
Edson, I guess the best way to say that is that breech babies are not safer. They are not safe for doctors.
Yeah.
They're safe for women. They're safe for babies. They are not safe for doctors, because nobody is going to help us if something goes wrong. And so doctors say, I don't care. I prefer to do a cesarean section with a lot of risks, surgical risks, anesthesiological risks, recovery risks, whatever, but I am safe. Doing a C-section, I am safe. And so the doctors need to do the balance between their own safety and the baby's and the mother's safety. Some doctors have this ethical, push to do, I don't care. I know it's risky for me, but it's better for my patients. So I will do that. But not all doctors do that. Many doctors fear something really bad will happen if they follow their intuition and follow the science and follow what is best for the mother and for the baby.
Totally agree with you, Dr. Ricardo. Totally agree.
Yeah.
That's the big fight. It's
Exactly.
lawsuits and that's why I've been traveling all over the world, because everywhere I go, I don't have a license there. I'm taking a risk every time I go into a country. I don't have a work permit there. I have nothing. I go to serve the woman who is well-informed, has made a decision that she's going to do the kind of birth she wants if I don't come even. But she would like somebody there just to support her. And so I'm placing myself in the forefront all the time, and trying to encourage more people to do the same. That's the only way we can help the consumer, is to just do what we know is right instead of the safe thing to do for myself. Yeah, I get it. I get it. I did it in Texas too. That's, yeah.
You're so brilliant. Mathus Mita wrote her question in the chat box. I think she's not able to unmute herself. She's written, yeah, I can hear you well. I have a question, which is not exactly related to this topic, but I want to know if there is breech delivery, then will we delay the cord clamping? And I guess Irene answered, we always delay cord clamping even until delivery of the placenta. If you cut the cord while it is still pulsating, you decrease oxygen supply to the baby. The breech baby's head shape is nature's way of allowing the easier birth of the head. We need a balance between what science can tell us and we have the tools to support the process. C-section is taken as an easier option, but it's not. And Zahra Khandejan, excuse me, up to when our class is on, my phone is going to cut off charge and the charger is not available for now. It's okay, my dear. Yeah, we are going to wrap the course now, because now we are 1 hour more than our supposed time. So thank you so much, everybody. Thank you so much, Dr. Edson, Dr. Ricardo, Irene, Gil, and all of you guys, Fatiha, Zahra, Farkhonde, Fatime, Zahra, Sadiqe, Reyhane, Milena, thank you so much for joining to our family. Indu, Mehnaz, Zahra, Farishte, Mehnaz, Ria, and thank you everybody. We are so happy to have you with ourselves. We see very beautiful, brave faces as a midwife and gynecologist all here in this screen from different parts of the world. We are here to help each other to save mothers and improve midwifery practice in different parts of the world. Thank you, everybody. See you soon. See you on. Yeah, please.
Alex,
yeah,
meet
please.
Alex.
Yes, thank you so much. So don't forget.
Thank you so much.
See you 14 July
Bye-bye.
for next session, everybody. See you soon.
Bye-bye.
And
We'll
don't
catch again soon.
Bye-bye, Irene.
Bye.
Talk to you soon, Ricardo.
Thank you. Susan.
Bye-bye.
Yes, we are
Bye.
soon,
Bye-bye.
Irene.
Bye.
See you guys. Love you. Me too. Pleasure meeting you.
Bye bye bye. Bye, Irene.
Love everybody.
Bye,
You need more
darling. Bye.
education and
God bless.
Everybody
Bye.
face
Bye.
your hand. I want to
Education.
see your beautiful smiling face and turn on your camera. Let's have a last picture all together. You Mehnaz, Ria, Mehnaz, all turn on your cameras. We want to see your smiling face. Yes. Thank you. Thank you, everybody. Take care.
Bye.
And bye.
Bye. Bye. Bye.
آخر هفته خوبی داشته باشید.